And now I'm going to open it up to all four of our presenters, Melanie and Katie times two, if you guys can pop back on. I've just been printing off questions here, hot off the press from the email for the conference. So I'm going to actually start with a question for, just seeing if I can see. Oh, there's Katie. Hi, Katie Caldwell. I'm going to start off, Katie, with a question for you. And this is sort of a compilation of a couple of different questions. Before I start, though, I do want to someone did make a comment for you, and it said, "I'm so very impressed by this strong, smart, resilient young lady. You have such a strong, compelling story. Adults have a lot to learn. Keep doing the great work that you are doing." So thank you. I think that echoes what all of us are thinking. Katie, if you met another 16-year-old who you suspected had CRPS, what advice would you give them?
Yeah, it's challenging to put myself back in the shoes of being 16-year-old. And I've been asked that before, and I think back to how much pain I was in when I was 16, but my brothers were still alive, and just if I would go back to that time, it's so hard to think about which was if the benefits outweighed the hurts of being in pain back then. But just thinking back to being 16 years old, I just really encourage you to try and find activities that are manageable for you if you are experiencing chronic pain. As a 16-year-old experiencing chronic pain, for me, I found running. I actually got into running not too long after being in IPRP, and even though getting back into activity did cause pain, ultimately I found it had a positive impact by getting into activities that I love doing, and just setting small goals and being kind to yourself. I feel like it's not an all or nothing type of thing where when you feel like you can't do a whole activity, you can be kind to yourself and just you can do a smaller activity or something less intense. Like for me, running didn't involve my arms, so that was a way to get active, and just finding things that you love doing will really get you back into being active, and then in the long term, you'll see decreases in pain, even though it seems counterintuitive that you might experience more pain when getting back into activity.
Thanks, Katie. And I really liked what you said earlier during your presentation about breaking everything down into really small goals. Mm-hmm. And I think that's important because I think sometimes it feels overwhelming what you're trying to achieve. But if you can break those down into small pieces and set small, realistic, doable goals for yourself every day, then I think you're going to see your success on a daily basis, which is great. And another question too was, do you think that finding a community of youth with chronic pain sooner would have helped with your feelings of loneliness and isolation? That's from the viewers out there.
I'd say finding that community of other youth who were experiencing chronic pain was so huge. I was fortunate enough to get into the IPRP program within a year of being diagnosed with CRPS. So there were other youth in that program who had gone quite a long time without meeting other youth experiencing chronic pain, and I feel fortunate that I was able to meet them so soon into my pain journey. I feel like it's been good, especially during the program, to help keep each other accountable and encourage each other and help each other out, because all of us were experiencing pain in different areas. So there were things that one person could do to help someone else out, and it's been really cool to grow with the fellow youth. I've been able to actually attend a wedding of one of the youth that we went to IPRP with, and attend university with two of the other youth, and it's been really helpful to grow those relationships. We really bond on a different level when you've experienced from my chat.
Thank you, Katie. This is a question for Katie Burney, but it may also be for Dr. Ali as well. How can 2/3 of kids in the hospital go through painful surgeries without any pain management? Do you mean without any involvement with the pain specialist?
So yeah, please, Dr. Ali, please feel free to add to. No, it means without anything. It means without getting topical anesthetics that we know are really helpful. It means without particular efforts to ensure comfort positioning. It means any of those pharmacological and psychological and physical strategies that we know can be helpful. That's what we mean. And there's so many contributing factors that lead to that. There are lots of potential barriers. Certainly lack of knowledge can be one, but it's not the only one. It's often attitudes that Samina was talking about in terms of beliefs that it doesn't matter, that it's quick. And Mel's written a great article that was called Pain's Not Over When the Needle Ends. And I think when you hear from patients and families that often those are the most traumatic kind of pieces. And some of those are systemic and organizational issues. You know, can you wait for the topical anesthetics? Misbeliefs about, you know, how does it change whether it can, you know, the ease of access, like those kinds of things. Samina, please go ahead and add if you want.
Thank you. I would just add to that the statistics I presented around appendicitis, those were prior to surgery. On World Anesthesia Day today, I'm quite confident that my anesthesia colleagues would have given them pain management intraoperatively and postoperatively. So those numbers of 60% not getting any analgesia was before they hit the operating room.
Yeah, thank you. As an anesthesiologist, I agree. I always give pain medicines for children undergoing GA. So yes, thank you for that. Okay, Melanie, there's a couple questions for you about, not surprisingly, about sleep. The big question. So just generally, the viewers are wondering about what strategies you would suggest to target sleep in children with pain other than looking at regular sleep hygiene practices. And then specifically, if you have children with neurodevelopmental conditions who have pain, how would you advise that they target sleep in that population?
Okay, thanks for the question. So the most evidence-based strategy or treatment for insomnia or sleep problems in kids and adults is cognitive behavior therapy for insomnia. Tanya, actually, when I was a postdoc, I was someone administering this treatment to kids. And Tanya's initial trial actually of CBTI, so it's 4 to 6 sessions. If I have to boil it down, what CBTI is, and I'm really simplifying, but I think being simple is good. It's encouraging, so it's sleep restriction, going to bed when you're really, really tired. Okay, which sounds counterintuitive, right? You didn't get a good night's sleep. You're like, I'm going to go to bed at 8 p.m. Don't do that. Stay up and go to bed when you're really tired. And number 2, the active ingredient is breaking the sleep onset association. So what you have when you have insomnia is you're in bed and you're awake and you're just lying there. And what happens is you start associating bed with being awake. And so another strategy is, so sleep restriction, go to bed super, when you're tired. And 2 is if you wake up, okay, and you're in bed for 15, 20 minutes and not going back to sleep, get out of bed. Break that association. So with kids, it's like we get really clever, we're like, build a nook in your room and don't go on your phone do something kind of boring. Back in the day, I remember Tanya saying she would tell kids to read the dictionary, but you could draw or do some just calming activities. And so that's essentially what CBTI does. Now, as a therapist, you're also calculating there's the kid's sleep efficiency, so the percentage of time in bed that you're actually asleep. But those are the principles. And so to address the second part of the question, what would you do with kids with neurodevelopmental issues? And I know Katie is leading some cool work on pain assessment and pain in kids with neurodevelopmental issues. The reality is a lot of our treatments are not, or trials are not conducted on kids with neurodevelopmental issues. That said, in Tanya's original trial, she included a wide range of kids, including kids with autism spectrum disorder. And I remember one of them was a patient that I worked with. You know, and basically she found that this CBTI treatment did improve sleep, even in this heterogeneous group of kids with a variety of, you know, neurodiversity and mental health and physical health issues. In my work, and I can let Katie chime in and Samina, when I have done clinical work, and it's been a while because I got 3 kids at home keeping me busy, you know, it's really the same principles apply, but how you deliver that information would be in a more concrete, visual way, and you'd be working really closely with parents as well. But I welcome anyone else. But it's basically CBTI. And Tanya's really leading the charge in testing those interventions.
I would really suggest that if you're really interested in this, Colleen Carney is the person to go and learn from. And everything that has been said so far translates to adults. Every single thing that's been said so far translates to adults. So just to add that little piece in, I think it's fantastic.
Okay, but we can't say that children are just little adults, because that's going to make.
I know.
Adults are big kids. I think that's
there it is. That's what I'm trying to say.
You're on your toes.
I may be one of the biggest kids. We are just big kids, but everything that is being said today translates beautifully, including the incredible discussion about trauma. And any pain program that thinks they can run pain without having trauma therapy or trauma-based therapy is just way out there. You have to treat some of the underlying conditions, including it was just so beautifully well done.
And I have a question here for Samina. This is also from the viewers. Should we encourage parents to use acetaminophen and ibuprofen before childhood immunizations?
Oh, that's a great question. And
sorry, I know it's a bit
yeah, it's full disclosure, that's at the limits of my comfort to speak to, because I'm not an expert in the immunology surrounding vaccinations. My understanding from my colleagues who work in that area is that we should be encouraging parents to use it after the fact if their child is in distress, but not preemptively. So don't pre-dose your child with ibuprofen and acetaminophen. And full disclosure, 15 years ago when I was taking mine, we were told to do that. So this is based on current new evidence, is don't pre-dose, but if they are symptomatic afterwards and the physical and psychological interventions are not adequate, then absolutely go ahead and dose them for comfort, but not pre.
I can add to that. I know I'm not a prescriber, but Dr. Anna Taddeo, which Melanie is also a co-author on, published clinical practice guidelines in the Canadian Medical Association Journal in 2015. And it's on top of mind because I presented about it to a group of pharmacists a couple of weeks ago, and there's no evidence. The evidence suggests against delivering a pre-analgesic prior to the immunization.
So just for all our viewers at home, so using those other strategies that Dr. Ali went through, comfort positions, distraction, etc., those would be the go-to tools for childhood immunizations.
And yeah, topical anesthetics, which I think Samina also talked about, but yes.
Thank you. Yeah, sorry. Okay, sounds good. Do we have time for another question? Looking, it's 10:44. I'm waiting for Rob to let us know. Any other final thoughts from our presenters?
Just thank you. This was great. And thank you, Katie, for joining us today too, and Nives for moderating the session. And, please engage all of us. I know, I can speak for, I don't know, Katie, if you're on Twitter and use it professionally, but the rest of us certainly do, and, are very open to continued conversation and dialogue and around all of this. So just really excited to have opened the meeting today too.
Yeah, I would just, again, just in awe of my colleagues and Katie, I just want to thank you again for, setting the tone of this entire event in such a compelling and important way. And if you want to do more research, get in touch with me and Samina and Katie, because we could do some stuff together. So yeah, just thanks so much. I feel so much Alberta pain pride right now. And just, it's such a great place to do pain science. And we're all friends, we're all colleagues. It's so collaborative. And yeah, thank you for being part of this and inviting us.
Yeah, and I think I speak for all of us when I want to thank the organizers of Pain Society of Alberta, Christelle, Rob, Sylvia, who's in the background. Thank you for giving us this opportunity, and thank you for letting us open this meeting, which was slightly stressful, but very exciting. So thank you all. And once again, I echo Katie and Samina and Melanie's comments. If there's any questions or comments, please don't hesitate to reach out to us. We're always eager to hear from Albertans and actually from people all around the world. So thank you.